Hello.
So, oh, hello. Hi, how are you?
Super. Thanks for asking.
Good, welcome.
Excellent.
So we've got all of our speakers now. I'm excited about this all-female panel, and now it's also chaired by a woman, so that's good. I think I've got a bit of a problem with gender diversity because my team was entirely women until we hired our first token male a few months ago. So I'm building a reputation here.
Can you all hear me now? Yes.
Yes.
Okay.
Yeah. Loud and clear. So we're just quickly going to check in with Nick. So I'll be back in just a minute, just to see when we are live.
Aisha, I met you in Naivasha, right? At AAS event.
Yeah, I was just looking at, I was saying, I've seen her somewhere before, but yes, exactly. Yeah. Hi, nice to see you again.
Yeah, you too.
Hi, welcome to the panel.
Oh, thanks. Is Solomon still with you guys? I haven't seen him in a while.
He's still our lab director, around and taking on more and more projects. So
I know that's him.
He's busy now. He's leading also our future of climate work for IBM research. So
okay,
yeah.
Great. I want to get in touch with you regarding some call that's out from the NIH around data. And
yes.
Have you know about it?
Yes.
I'm sure that you guys are also, but we're going to put something together. We've been approached. So
yeah, we can't lead because we're
No, we can't. But we would like to work with the people who have the knowledge in different areas. You guys obviously the technical.
Yep,
we have the networks and the research community that we fund. So
sorry to interrupt, Isivani. I'm going to let participants in now. So
okay, sorry.
Starting now.
Great. So welcome all the attendees. I can see everybody coming in now, which is good. So we'll just give it another couple of minutes to let more attendees join, because I think they've all been patiently in the waiting room, and then we can kick off. Sorry, I'm on mute. In the interest of time, I think we'll get going now, and as more people join, then they are welcome. So thank you to everybody that has joined so far. Welcome to the second webinar in the three-part series hosted by BOBAB and Medixis, looking at COVID-19 Research Alliance. So today's event, as it's appropriately titled, is One Size Fits All, ? Incorporating social sciences in holistic approaches to tackling COVID-19 in Africa. So we have, I'm Nicole, I'm the CEO and founder of Medixis, and I'm also going to be the chair for today, making apologies for Dr. Karanja, who is unable to make it. So Bobab and I have teamed up to combine forces because we're both passionate, both our organisations are underpinned about sharing knowledge and enhancing collaboration on the continent. And that has never been more important than now with the rise of COVID. And that applies both to working doctors, collaborating with each other, researchers collaborating with each other, and also crossing the silos that sometimes exist within research, policy, academia, business, and medicine. So we're aiming to try and bring all of those things together in a three-part webinar series. So never let it be said that this isn't ambitious. So the primary aim of this webinar is to promote the intra-African and interdisciplinary research collaboration and its role in this fight against COVID, but also highlighting some of the challenges that a lot of African academic and research institutions face around lack of funding, physical resources, challenges in getting published. And so for this event in particular, we've assembled an expert panel to share their thoughts, and I'll give you a quick overview of their bios shortly. But first of all, we'll go through the house rules. So everybody that is joining as a participant, we've done this in a webinar format, so you'll notice that you're not able to speak or have your videos on. But if you are invited to speak, make sure that your microphone is muted, especially when other speakers are presenting. After each presentation, we're going to invite a couple of questions to bring to the panel, to the speakers. So please type your questions, have them ready. We're going to make this interactive, so it's not just us speaking at you the whole time. And we'd love to hear your thoughts and contributions. And you can do this by either typing a question or raising your hand if you want to ask it and you know, use words the old-fashioned way. And we'll approve you to do that. So those are the basics of it. I'm going to quickly hand over to Nick to give a brief introduction, and then I'd like to give an overview of the speakers.
Thank you, Nicole. And hello, everyone. Thank you for taking the time to be here. As a very, very quick introduction, for those of you who don't know, BOBAB is an event streaming and peer-to-peer networking platform dedicated to connecting science, tech, and business professionals working in and for Africa. We exist to accelerate science and tech and innovation happening in and for Africa. And we do that by working with partners like Medixis to design and host events and workshops that make it easy for experts like all you guys today to come together, to connect, to explore challenges, to promote innovative solutions, and ultimately, we hope, to enhance collaboration. And I'm really, really happy to be collaborating with Medixis again. This is our second collaboration and co-producing this series. They're an organisation I know doing fantastic things on the ground in Kenya in particular, connecting doctors and facilitating knowledge sharing. Yeah, and as Nicole mentioned, this series is all about bringing interested parties together, forming an alliance around a shared and specific purpose, namely exploring and promoting the significance of intra-African and interdisciplinary research in the fight against COVID-19. We think it's really important, of course, but we want to help spread the word and beat the drum for the significance and importance of interdisciplinary and collaborative research, and also showcase some fantastic individuals and organizations who are doing great things. Today, we're looking at the challenges and the opportunities of developing effective, contextually relevant mitigation strategies and policies in the fight against infectious disease. And we have a fantastic range of experts from really, really diverse backgrounds who I know are going to help us do that. So without further ado, hand over to them. Thank you.
Great. So quickly, just as an overview of who we've got with us. So we've got Dr. Naika, maybe you give a wave so people can identify you, who is the Director of Strategy and Partnerships at the African Academy of Science, based in Kenya, which is a Pan-African organisation with a vision to transform lives through science. And prior to this, Dr. Naika worked as Chief Director of International Resources at the Department of Science and Technology in South Africa, and has also been a Research Associate at the University of Cambridge and a visiting research fellow at the School for Public and Development Management at the University of Witwatersrand. I hope I said that right. So we're really lucky to have someone with such a broad range of experience and views involved. And I know that Dr. Naika has recently written a wonderful and passionate blog focusing on the missing voices from South Africa's response to COVID. So really interested to hear her perspective. We're also joined by Dr. Kate Webb, who is a paediatric rheumatologist at the University of Cape Town. So Dr. Webb specialises in paediatric rheumatic conditions, including juvenile idiopathic arthritis, juvenile onset systemic lupus, erythematosus, that's a tough one to say, and in addition to general paediatrics. So Dr. Webb has trained at the Red Cross Children's Hospital at the University of Cape Town with a Discovery Foundation subspecialty fellowship, and has also been awarded the Competitive Action Medical Research Fellowship to complete a PhD at University College London, UCLH and Great Ormond Street Hospitals. And Dr. Webb brings a really interesting perspective of the paediatric angle of COVID and the impact, because a lot of policy and mitigation strategies to date have focused on adults, particularly those above the age of 50, who are considered to be the most at risk, and children are largely left out of that conversation. So we're really excited to have a paediatrician involved to give that much needed alternative perspective on the risk posed to children by COVID. We are also joined by Dr. Aisha Walcott-Bryant, who is Research Manager at IBM Research Africa. And Dr. Bryant is a research scientist and manager at IBM, and she leads a team of researchers and engineers that really excitingly use AI, blockchain, and other technologies to develop innovations in water access management, healthcare, core AI, and particularly focused on emerging countries. And I know Dr. Walcott has a very strong interest in global health and development, and earned her PhD in electrical engineering and computer science department at MIT in robotics. So not an overachiever at all. And she's also a member of the Computer Science and Artificial Intelligence Lab. So Dr. Aisha is going to bring in some really interesting perspectives on her previous work related to malaria and how AI can help with that. And we really want to emphasize and get her perspective on the important role technology, big data, and emerging tech has to play in some of these mitigation strategies. And last but not least, we're joined by Professor Mathai, who is Associate Professor and at the Department of Psychiatry at the University of Nairobi. So she graduated as a doctor in 1983 and was awarded a master's degree in psychiatry, and also has a PhD from the University of Kassel in Germany. And Dr. Mathai returned to Kenya to take up her teaching position at the University of Nairobi in the College of Health Sciences. And she's a mental health researcher with diverse interests, and is also the principal and co-investigator in several studies, and is currently working on an initiative that provides psychosocial support for frontline healthcare workers, which has never been more important than a time like now, where they're really overworked and often left out of the conversation. So really excited to hear more about that. And obviously, Dr. Mathai brings a really interesting perspective, as I say, on the mental health burden on healthcare workers, and also, the role that government can play in increasing support for healthcare workers and the stigma that patients sometimes face when they test positive for COVID. So I'm sure that everyone who's dialed in now can agree that this is a really excellent, high caliber quality of speakers. So I'm really excited to get started with them. So I think the first speaker will be Dr. Naika. So each speaker will present for approximately 12 minutes, and then we'll have some time for Q&A. And then after everybody is presented, we'll have a bit of time for open discussion and a Q&A session. And so without further ado, over to you, Dr. Naika.
Great. Thank you very much, Nicole. And thank you for everyone who's joined us, and welcome. And it's really an honor to share this platform with such a amazing array of guests, very qualified, and great that we're all women. It's coming into Women's Month, so I think it's well timed. So I thought I would start with just who the African Academy of Sciences are, to those that who've joined we don't know, and then going a bit to our work regarding the response to COVID-19 and what's come out of that, which does point to the need for more social science research. Specifically, I'm taking it from a research angle because my colleagues will be looking at more at the practitioner angle. So I wanted to just give you the first slide, please, Nick, the next slide. What we are, as Nick said, a Pan-African organization. And I just wanted to give you a sense of Africa is a very large continent. And if you look at the countries of the world, it fits into the total land area of Africa. And we have an interaction of various elements that are profoundly shaping the future between human, environment, health, etc. And this pandemic, obviously, coming into the continent with these very diverse range of realities, socioeconomic, health, etc., has created a real crisis. But before this, next slide, please. In 1985, when the World Academy of Sciences was created in Trieste, African scientists were put with a challenge. Wasn't there need for a continental academy? And our founder, Professor Odhiambo, who also founded various other institutions, including ISIPA in Nairobi, took on the challenge and created the Academy of Sciences, which is based in Kenya, but it represents scientists from across the continent. And this just gives you a timeline of the history, but I won't dwell on that. Next slide, please. Just wanted to give you an indication that we have got our head office in Kenya, but we have offices in and vice presidents in 5 countries in Africa. We're non-aligned, non-for-profit Pan-African organization. And our vision, as Nicole said, is transformed lives through science. And how do we do this? Is that we look at leveraging partnerships with international funders, with the African governments, to invest in research excellence and thought leadership for sustainable development on the African continent. We are the only academy that's supported by the African Union Commission and the African Union Development Agency. Next slide, please. So coming to the social sciences, when we look at our strategic thematic areas, as you can see, health and well-being is a very strong focus of the work that we do, environment and climate changes. And then we look at social sciences and natural sciences. The reason why this is the case is that as an academy, we recognize scientists from across the spectrum of sciences. And in order to do that, we really need to make sure that we are supporting research in all of these areas. Through the history so far, we've done very well in health and well-being, and we've been through the Developing Excellence in Leadership and Training Network, DELTAS, which many people may know, have funded around 11 research networks across the continent. Our Human Hereditary and Health, which is trying to map the African genome on the continent, all of them focusing on health. We have some programs in environment and climate change, but in the next round of the DELTAS funding, which was opened until I think last month, we want to move more into the social sciences and humanities. And in this regard, we've hired a senior program officer to look after this portfolio within the African Academy of Sciences. The natural sciences and policy and governance are also other areas. So the next slide, please, Nick. We have a tripartite mandate. What I was just describing to you is some of the programs, but the first and foremost, we recognize excellence through fellows being nominated to become part of the academy. And these are the top scientists on the continent who are undertaking research to the highest level, who are recognized by their peers. They belong to national academies as well, but the best of those are also nominated to become fellows of the African Academy. We also provide think tank and advisory functions around shaping science, technology, and innovation strategies, certain positions in certain areas around climate change, health, genomics, data, etc. And then importantly, through these partnerships where we leverage funding from international partners, we actually act as a funding agency for programs that address Africa's key development challenges. Next slide, please. So how we do that is through a platform called AESA, which is the Alliance for Accelerating Excellence in Science in Africa, which implements these programs. And as you can see, what the pillars are around building these research and development infrastructures on the continent through the programs, including the Deltas, which is funded by the Wellcome Trust, H3 Africa by the National Institute of Health in the US. We have the innovation program, which is the Grand Challenges Africa program, which is supporting the innovation and entrepreneurship pillar. Then leadership, where we focus on earlier career researchers, the next generation of scientists in Africa. While we recognize on the one hand excellent scientists, we recognize that there needs to be a pathway for development of scientists once they finish tertiary education. So we have a range of fellowships through our Rising Leaders Africa program. Then we also look at critical gaps in terms of research uptake and management, including around policy advice, developing our think tank and research functions, looking at research system strengthening, because that's a key element of, you can fund the researcher, but if they're working in a not very good environment. So through the research management program, Africa Rempro Africa, we are working through the various research management agencies, including the Southern African, West African, East African, Sarima, Warima, etc., to support them in developing the research ecosystem there. And then a cross-cutting around that is around community and public engagement, science communication, and importantly around sustainability, Coalition for African Research and Innovation, where we're looking at ensuring that African governments come to the table to invest more in research, because a lot of the funding for science is coming from international sources for our work, certainly, but also within country. How do we get African governments to commit to the 1% of GDP that they've committed in the Abuja Declaration to the African Union? Next slide, please. Nick. So I just wanted to give you an overview of the work. Obviously, since this pandemic has hit the continent, we have stepped into gear very quickly as the African Academy of Sciences because we have these network of research excellent scientists across the continent and associate researchers elsewhere in the world. We held a first webinar on the 26th of March, where we wanted to just develop what are the common thinking that's coming from the researchers around what do we need to do to define a research agenda for the COVID-19 pandemic. The WHO had outlined a global research agenda, but we felt that we needed a specifically an African perspective. We're around 275 scientists attended, and from that we have developed a document which I could share around what are the research and development priorities for Africa to address the COVID-19 pandemic in the short, medium, and long term. And what's interesting, we had great interest. We also then undertook a survey collating these priorities following the webinar, where more people were able to join. And then we developed lists of the experts that we could draw on. And we've been working very closely with the WHO Afro and the Africa CDC in this work, and through the development of these research and development priorities, have also been working with the Global Health Network in the work that they're doing around research and development priority setting for COVID-19. Well, we did launch a call for COVID-19 call on the 1st of May that looks at picking up on some of the areas that were identified by research, but because of the quick turnaround time, it was focused on the existing research, the grantees of the AAS. Similar call was launched by the South African government in partnership with the National Research Foundation and IDRC, and it was also focused on existing grantees. The reason being is that to go through a review of open call takes a lot of time, and then also the systems you need to put in place. So in this first round, it was a closed call. Yes, could you go to the next slide, please? So the AAS's role, we are convening African and global scientists, policymakers, and funders to discuss this pandemic and what it means for the world. And specifically, we are, as I've just discussed, around supporting the research base, but also very importantly around science policy engagement. So we have a COVID-19 response team, and within that, I'm leading the science policy engagement work. And what we're trying to do there is work with the Africa CDC, WHO, plus also African regional economic communities who have science, capabilities where they have the access to the policymakers. We have the access to the scientists, but to get them to talk to each other is very important, because as we know, we are learning very quickly. The responses across the globe really have been shifting, and more it's the necessity of looking at the scientific evidence and not what people are saying through the news media, etc., is becoming very important. And in this regard, we want to be able to have direct access to policymakers through these different communities. And we find that's a very important area in terms of the social scientists and policy and governance, where through the ministerial advisory committees, which have been set up in some countries, South Africa has got a strong advisory committee, but as I note in my opinion piece, which Nicole mentioned, there are missing voices, because you have scientists and you have largely scientists with medical professional background, but there's a lot of issues that are coming around delivery of services. How do people access services, even testing, and the mental health issues that require the social sciences, but also looking at how this is playing out, how have the medical, epidemiological, and other communities come to the table, really requires a kind of social studies of science as well, which will help us learn and prepare for future pandemics. Next slide, please. So I just wanted to give you an overview of the research and development goals that were unlocked from this survey. And what you can see, a large portion of them is around clinical, epidemiological, and virus, natural history, etc. But importantly, from the scientists as well, the last two, I have highlighted integrating social sciences in the outbreak response was identified as a very important priority area, not as an area, but a priority area that needed to be addressed. And also this also includes then the ethical considerations for research, considering that, we do need to be doing clinical trials very quickly, etc. We are still going to be diving into that social science response and how do we better undertake research. So as I said to you, even within our ongoing work, the focus on social science needs to be improved, but this pandemic is actually pointing the finger to say that actually in pandemic response, but also in general research and development going forward, the role of the social sciences really needs to be brought to the fore. Next slide, I think that's the last slide.
You. Okay,
and
great.
So I just want
Thank
to
you.
give you some of the way forward. Yeah. So this is basically what we're going to be doing. I just went through it. We've developed a clinical trials community program, our public policy and engagement activities. We're convening research on the priority areas through research groups, and developing work packages that speaks to some of the information that's coming out from specific countries where when we're working through science policy engagement, we want to look at specific countries that need assistance, which don't have advisory committees, and how we can support them through this process. The next slide, please, which is just basically the platforms that we use to undertake this, and then the last one, which is the partners that support us, and we'd like to thank them. As you can see, variety of supporters, including African governments, but largely international funders. And thank you very much, everyone.
Great, thank you, Dr. Naika. That was a really useful, informative presentation, so thank you for that. I'd like to open the floor to any questions. So if anybody has any questions they'd like to ask Dr. Naika, then you can pop them in the chat, which we'll be keeping an eye on. And just to get started with a question for you, you mentioned that you are doing science policy engagement work and have this sort of cross-functional discussion with the policymakers. Are you able to share any more insights into some of the early outcomes or findings of those discussions so far?
Well, the discussion so far has been about what are the needs from those countries. And then the next phase will be, we will be looking at developing a series of consultative workshops and not webinars, but so the key thing that came out for now is that in certain African countries, they're basing their response on international, best practice or what's being done in Europe and the States, but that doesn't necessarily, serve African countries very well. So in South Africa, our advisory committee is able to give a response based, and possibly in Kenya, but other African countries no. So what we want to do through that is to not just engage at the regional level, but to identify countries. For example, the African Union Commission identified Malawi for who we can engage with, where we can bring our experts to the table, bring some of the policymakers, listen to what are some of the questions and areas that they need specific advice on, and then commission rapid research synthesis based on knowledge that exists within the country from previous work, and give them some very key policy recommendations that can help them in the work. So that's
right. That's very useful. Thank you. And we've had a question from Dr. Walcott-Bryant, who has said that Africa experiences outbreaks frequently. What are the key differences between our outbreak preparedness and response and what we do differently for COVID-19? And are there existing tools and protocols that put us at an advantage because of our existing disease burden? Which is a really interesting perspective. Thank you.
Yes, specifically, I think around the Ebola, I think people know, but the Ebola outbreak, I mean, we have various other outbreaks, but they're not as, jarring. The Ebola outbreak, and I think some people have not in South Africa, the outbreak has been pretty fast and rapid, but in other parts in Africa, people have questioned why it hasn't erupted. Some say it's probably because, Aisha, it's the lack of data on the numbers rather than a better response. But some others say that it is because of, in West Africa, there's a West African Health Authority, a whole range, and the way they responded to the Ebola outbreak the last time, and some of the mechanisms they put in place for emergency response, etc., could have helped them in addressing this outbreak. But specifically in terms of that's more in terms of service delivery. But in terms of research and clinical trials, a key thing that we are learning is that we are very on the back foot here. Firstly, because of the ability to undertake clinical trials for new medicines. Some of the work we've done through the Human Genomic Project is, if these things are developed in other parts of the world, how effective are they going to be in Africa? Because a lot of the African genome is not being sequenced, so if they use precision medicine stuff, so it's going to be an interesting. So I think what this is making the case for, very importantly for Africa, is the need to invest on an ongoing basis, not just during the pandemic. We do have resilience, I think, which is a good thing, but not actually. You really need to be able to be able to have the infrastructure, the research base, etc., to respond. We cannot solely depend on resilience. And I think so. I hope I answered that question. But so I think we have learned from a few of it, but we have a lot more to learn and a lot more work to do.
Great, thank you so much for that. And on that note, I think we'll introduce our next speaker, which is Dr. Webb, so our paediatric rheumatologist from the University of Cape Town. So Dr. Webb, over to you.
Hi, apologies. I am having issues with my connection, so I'm on the phone and on the internet, but at least we'll have a backup if anything goes horribly wrong. So thank you for having me. It's a real pleasure to be involved with this amazing crowd of people, and it's a pleasure to be here and speaking about what I've been doing and our approach to COVID in children. So I think we're quite I'm not sure if we can say we've been lucky or if we've been unlucky in Cape Town being the kind of sentinel epicenter of this pandemic in Africa as it's spread throughout other regions. Well, it's sort of started here, and we've had a high number of cases as compared to other regions in Africa so far, but we are watching it spread to other regions. And what we've quickly learned, that one of the best things about this pandemic, if there can be a good thing about it, is that it seems to spare children relatively clinically. So at the beginning, we cleared our wards in preparation of finding many patients with COVID-19, many childhood patients. I work at a children's hospital specifically. But it became very clear early on that children were not as affected as adults. And we had very few patients who were admitted unwell with COVID. We found that it affected our staff much more than it affected children in general, and far in excess staff were infected than we were admitting patients. This is not to say, however, that children are not directly affected by COVID-19. And what we quickly found, that children are disproportionately affected by some of the effects of things like the lockdown and the economic burden of disease. Children are disproportionately affected by poverty and hunger, and were exposed to domestic violence and abuse, and they have lack of access to education as well as other social and health services. So that's just a little bit of background about the pandemic clinically in children as well as socially in children. And very early on, we worked together in South Africa to gather a coalition of clinicians to look at cases of COVID-19 in children and quickly try and discover whether there were predisposing factors or other things like that that made children more likely to develop COVID-19. So I just want to, sorry, could you give me 1 second? It looks like I'm back online. Yeah, I'm just going to swap back over to my laptop. Apologies, I'm back here.
No problem.
I'd like to speak about inflammatory syndrome in children.
Webb. Oh no, we've got you back now. Sorry, we lost you for a second.
Sorry, am I here?
Yes.
Apologies, am I back?
Yes, but I think there's a slight echo, so you may need to mute your other device.
I'm so sorry. It's all gone.
There we are.
Obviously, horribly wrong. So there has been this emerging syndrome of multi-system inflammatory syndrome in children, which was first reported, next slide please, in the US, well, in the UK initially in a small case series of 10 children. And there were a series of articles from the US in late June. This is one of them, looking at the cases in New York. And what they started to show is that into the pandemic, cases started to emerge of children who developed this very inflammatory disease, presented with fevers and rashes and red eyes and abdominal pain, but also were quite profoundly shocked and required quite intensive care and admission. And this outbreak seemed to follow the pandemic by a couple of weeks to a month, So it's been postulated that these children have developed a post-inflammatory hyperimmune syndrome. And what was striking about these cases in the US and the UK is that there seemed to be a disproportionate amount of children who were from Afro-Caribbean and African-American origin. And so we really paid attention quite early on, and we prepared ourselves to expect to see these patients. Next slide, please. Quickly, the WHO, as well as the CDC and the Royal College of Physicians and Child Health, all put together slightly different criteria to diagnose these children. And as you can see, it's pretty general in that it's got a large age range. A child has to have a fever for more than 3 days, red eyes, they have to be shocked. It can involve their heart and often involves gastrointestinal problems. So we've had a few kids who've had, gone in for appendectomies and things like that, and that was seen in other centers as well. And actually they have MISC. These children are very inflammatory with high ESRs and CRPs. And of course, we have to exclude other causes of inflammation. But what can be challenging in our context is an evidence of COVID. So either a previous positive PCR test or testing for serology, which we don't have access to, or likely contact with patients with COVID. So what we found is that patients at the very beginning, our first few patients, often the parent might have had a positive COVID test, but as we've been going forward, that there's been a lack of studies. So if I can just briefly talk about our experience so far in Cape Town, this is just taken directly, this picture is just taken directly from our provincial website, which shows the number of cases to date. So as you can see, on about the 29th of June, there was what we think may be the peak of our cases per date. These data don't really reflect the peak because we have changed our testing criteria after that. But as you can see, we had a higher number of patients towards the end of June and July. And between us and Tygerberg Hospital, which is the other referral hospital, we've seen 23 cases. The first was on the 4th of June. And these kids range in age from 6 months to 12 years old, but we're finding that it's generally older children with a median age of 8. Only 4 of the 23 were COVID positive, so generally they're not actively infected at the time and not SARS-CoV-2 PCR positive. And our children present very much like the other centers have, with fever, tachycardia, rashes, red eyes and conjunctivitis, and quite severe abdominal symptoms. Next slide, please. So with the children that we've treated so far, we've been extremely fortunate that we haven't had any severe outcomes, and all of our children so far have gotten better. We have about 9 currently admitted between the 2 centers. And the majority of children have received IV immunoglobulin, which is not based on evidence, because obviously this is an evidence-free zone as it stands, but it's because of the phenotypic association or similarity with this syndrome and Kawasaki disease, which is an auto-inflammatory autoimmune vasculitis that we treat commonly. These kids have also received methylprednisolone, about 65% of them, which is a commonly available steroid, and only 2 have required tocilizumab, which is a highly specialized IL-6 biological inhibitor. These children have been pretty unwell, so 26% of them have been ventilated, and half of them have required ICU, and 10% of them have required dialysis. But on average, they stay in hospital for about 9 days, and so far we haven't had any deaths from this syndrome. So I think what's important here is to think about, as this progresses throughout the continent and throughout the country, whether these drugs are going to be available. And I know IVIG is extremely expensive, and we usually use it in quite small quantities. But for this, because these children tend to be older and they're previously well children, we're using large volumes of IVIG, and we do have concerns about how easily accessible that would be and how affordable that would be. It's an extremely expensive therapy, and also how appropriate this is. As we said, this is an evidence-free zone, and we are learning as we go, so we're urgently in need for more data. Next slide, please. So my key message that I'd like to just get out is that this seems to be coming on our continent, and I think it's, although a very rare condition compared to the overall burden of coronavirus, we need to encourage local pediatricians and child health practitioners to be vigilant, to plan in advance for centralized or structured teams who have expertise and have been prepared for this, and to have referral centers and referral pathways for these children. We need to have urgent data collection and international cooperation. And there is an international study called the Best Available Treatment Study, which is not a randomized study at all, but people will be entering data about which treatment children were given, and we'll be able to do some post hoc analysis on that, and that's based in the UK. We need to think about appropriate and local guidelines for our patients, and we need to really think about creative resources and access to treatments like IVIG and how we're going to make those universally available to children and whether that's appropriate. Thank you. And apologies for all my technical issues.
No problem. It's a testament to the resilience you powered through. So thank you very much for that really interesting presentation. Again, those who are watching on the live stream, we invite you to ask any questions that you'd like to in the Q&A. But to kick off, I think I was particularly struck by what you said about the treatment at the moment being not evidence-based, unfortunately, because there's a lack of evidence, and also how severe it can get in children. So are we seeing higher rates of MIS on the continent versus other continents, do you think? Is there a genetic component to it that you believe might exist?
Thank you. Yeah, that's a really good question. It's a really difficult thing to say because we just don't have enough data at the moment. Out of these 23 children, anecdotally, we know that about 43% of our population in Cape Town is Black African ethnic origin, and about 78% of these children, which is a very small number, have been Black ethnic origin. That mirrors the data from other centers. If we look at how Kawasaki disease looks compared to these to MISC, we can make some correlations, and Kawasaki disease usually is the most common in Japan. They have much more Kawasaki than anywhere else, and they're not seeing the same trend. So there's many variables that can be involved, including pre-existing immunity, exposure to other infections, nutritional status, socioeconomic status. But I think that it would be also really interesting to look at whether our patients have a pre-existing genetic predisposition to this hyperinflammatory inappropriate immune response.
That's very, very interesting. And have you seen in South Africa, in your experience, this being factored into policy at all in terms of like the way we're thinking about opening schools or opening playgrounds and things like that?
It's a really also a very good question. I think it's such a difficult one because we know that the lockdown disproportionately affects children, and I feel like, with the risk to children from coronavirus, we would quite like to see kids get back to school. Although this is developing, the frequency is still extremely rare, and at the moment we don't think that it should influence those decisions, but we are keeping a very close eye on this and trying to communicate it quite quickly. I think that the most important thing is that people know to expect these children and know to diagnose it, because if that's the case and we find them and treat them, they seem to do quite well. But if they're not diagnosed, I think that we could run into problems. And I have a feeling that's not based on evidence that we may see more of this in Africa than we see in other places, just because of what we're seeing so far.
Right. Thank you so much for that. That was really, really interesting. So anyone who didn't get a chance to type a question quickly enough, you'll have another chance at the end when we have an open floor for questions. So in the meantime, I'd like to introduce our next speaker, Dr. Walcott Bryant. So over to you.
Okay, great. Hi, everyone. So today I'm going to talk about more on the technical side of AI for disease intervention planning. And what's nice about this work, it's work that we were doing focusing on malaria because of the burden of that disease in Africa, but how the framing of this problem, the way that we framed it in our approach, has lent itself to actually allowing us to help address COVID-19 as well. Next slide. So let me talk about this from the malaria perspective, and then as I wrap, I'll show the parallels so you can see where we are with the COVID-19. So we all know kind of the big problem around malaria, and some of the key statistics are that every 30 seconds a child dies somewhere in the world because of malaria. 90% of the cases are in sub-Saharan Africa. And then in 2018, so when the last report was out that we had looked at, more than 400,000 people died from malaria. And again, in this case, we all know that malaria is it's preventable and can be treated with antimalarials, and transmission can be prevented with effective malaria control. So our focus will be on the malaria control side. Next slide. So as I mentioned, we're looking at malaria control, and what we're really trying to do is look at the decision support for malaria control. You have decision makers or policymakers like your different teams within the Ministry of Health that are focused on malaria. You have modeling communities, so rich modeling communities out of many different institutions, whether they're academic or research for decades or so. And then we have a range of interventions that we can apply in order to effectively control the spread of malaria in different geographies. And note, every location is different, and therefore trying these types of interventions actually varies quite a bit. And we don't know what is the best set of interventions to try for a certain location. And then even on top of what is the best or the optimal set is, what proportion of each? Should it be all households have spraying? Should it be everyone gets a net, or should it be half the population? So that actually makes this problem challenging from a decision-making perspective. And on top of that, what else makes it challenging is the ability for decision makers to access these malaria models, which are generally very complicated. So we're here to kind of bring these elements together to support decision making. Next slide. And the way that we do this is we use methods within AI that support or help with decision making with uncertainty. And one of the key areas or frameworks is called reinforcement learning. And generally it's used for sequential decision making, where you need to make a set of decisions in some specific order to reach your target, and you have a set of constraints. So now you have your malaria models in which you have inputs like the different interventions. So it could be spraying or nets and so forth. And we want to say, okay, which combinations of these interventions will help a specific location to reach their target? Target could be a reduction in prevalence from maybe 25% to 6%, could be a reduction in mortality of the disease. And then of course, many of the locations, at least in Africa, they're very constrained by budget. So you need to be able to bring all these into your decision-making framework. And there's a lot of techniques within reinforcement learning that can support that. Next slide. So what I want to do is highlight some of the findings that we've gotten from doing this work, and then I'll give a couple example case studies. So we've used this method for doing what we call, let's say, one-shot intervention planning, and that's basically try some set of interventions and try to find the best one according to some function or whatever criteria you want to optimize. Can be, again, can be like mortality or prevalence. And we use that method. We basically sample the space of all possible interventions that can be done and find the most cost-effective that reaches the target. And then on this slide, on the left, the tree actually shows this notion of sequential decision-making. So often you see malaria intervention programs where teams come together, they convene, they read the literature, they talk to modeling communities, talk to different experts, and then they set out with a 5-year plan. Well, now we can actually help that process be much more flexible and reactive. And what this does allows for planning and changing the type of plan from year to year or at any time scale. It could be 6 months, it could be 1 month. And now you can see in parallel with COVID-19, we would want to be able to develop the right intervention plans, maybe at a 1 week to 2 week level or scale. So that's what the left shows. And that's kind of a very, a new kind of finding or just a new way of thinking when it comes to malaria control in that community. But it's a method that's very well known in AI. So the beauty of it is bringing these two fields together. And then on the right side, what you see is 2 graphs. The blue graph shows that notion of what I said, one shot. So just try a range of interventions and see which one is the most effective for your goal. And that's the blue. And even in that space, when we did that work, we did find intervention plans that were different than what was commonly used in specific locations. We had a case study for generating some of this as an area in Western Kenya, and applied our methods there. So that was great to see that there were other approaches than what were being implemented and what were thought as optimal. And then we took it further by implementing this multi-step, or what we call, sequential decision-making. And what you see here is that the orange dots represent that. And let's say the prevalence is the red line, and let's say it's 6%. You find the orange dots actually reach the target prevalence for a lower cost. And that's a huge win, especially for resource constrained economies, and also a change of thinking to derive such plans. So I think that the potential of this is very, very strong. I'll give an example of a case study in which we're applying these methods. Next slide. So we're working with Uganda, and their overall goal is, our overall goal is actually in collaboration with them, is to see if we can generate new malaria intervention programs to reduce prevalence and minimize deaths in Uganda. And they have a specific target that by 2025, they want to drive the malaria parasite prevalence in all 134 districts of Uganda to 5% or less. And you can imagine they're all starting at different percentage of prevalence. The environment is different. So techniques such as AI and the methods that we've developed are actually very important in this decision-making process. Next slide. There's quite a bit of similarity when you think about reducing the spread of COVID-19. Again, we have decision-making teams. They're often called COVID-19 task force. They have a set of targets, whether it's containment, economic disruption, mortality, and they have constraints that we've all seen and read about in the news. Again, there is now a modeling community, obviously not as long-standing as malaria, but from that we can get some projections and some outcomes. And then there's these interventions. So really, in this case, you want to say, well, what can we do? What are folks doing, or different countries around the world doing, and which ones are relevant to my context? So again, you have this decision-making problem, know what interventions to implement and when to actually lift them. So we actually leverage the same methods that we're using for malaria, but in this case, there's a catch. This is a brand new disease. We actually have a much longer pipeline. So we started a process of using techniques in order to even collect a data set of what interventions are being done. Next slide. So we've done this process of using different AI methods, specifically NLP, to understand what types of interventions are being implemented worldwide. And now it's been recently released on the IBM COVID-19 dashboard, so you can see that. If you go to the view about non-pharmaceutical interventions, you can see that. And the main aim, we'll release a separate version that's geared towards the scientific community. So this one's just to give a high-level understanding of the different types of interventions implemented. But then again, from a scientific perspective, we want to get into the modeling and a causal effect analysis of how these interventions perform in different geographies to support decision makers. So that will be released in a later date, and we will engage mainly with the scientific community, but it's also for public good. Next slide. So just to wrap, this platform and the AI techniques that we've been developing have been used in a number of scenarios. What's key about it is that it's bringing together the decision and policymakers, modeling communities, and AI community in addressing these large global health problems. And that's something that's not necessarily so common, but now that framework exists. As I mentioned, COVID-19 was an example applications, but we've also explored it being applied to HIV/AIDS, many other diseases. And actually, it turns out it's the framework itself is agnostic to the types of models. So it doesn't have to be just disease models. Anything in which you need to do an intervention to reach a certain outcome, this platform and the set of techniques can be leveraged. One of the cool things is that we've had this featured at a number of AI conferences, including Deep Learning and DABA here last year in Kenya. And I just want to acknowledge, we can go next slide, all my research colleagues that have been working on this effort, and look forward to the discussion. Thank you.
Great, thank you so much for that, Dr. Walcott-Bryant. That was really interesting. I was typing notes away as you were speaking. So once again, questions open to the floor. But to kick things off, interestingly for me, what stood out is that a big difference between malaria and of course COVID is that malaria has been around for a very long time, and we have huge amounts of data on malaria, different interventions. How does that translate to using this model with COVID-19? I know you mentioned you were exploring a few different AI models, but the interventions, I suppose, that have been implemented globally are quite fragmented in a lot of ways. So it's very difficult to have a huge data set on one intervention in particular. So how is that translated for you?
Yeah, I mean, it's just like you said, it's real-time science. So we don't have historical information and data like you would have in malaria. But we have the learnings from epidemiological modeling and other areas. And then we also have, because we have newer techniques, right? So now you are seeing technology being used for contact tracing. In our case, it's intervention planning in ways that obviously did not exist in the past. So I think that helps to address some of the challenges you mentioned. But you're right. When it comes to modeling, if you don't have sufficient data, it's very hard to have very good predictive models. And then understanding causal effect of these interventions that are estimated. We do see studies that are coming out maybe for a certain set of countries to understand. I think that's the start. But again, it's real-time science. We are here to provide the framework. The framework uses blockchain so that you can have some level of transparency. We're not necessarily modelers. We do have those people who model in our organization, but we allow for the onboarding of any types of models onto the platform. And then for us, we really bring in the AI perspective to explore those models and to sample them for decision makers. Yeah, thank you.
Thank you. Thank you for that answer. Any questions from the platform or from the chat, Nick? None that I can see. Okay. So I think you've gotten off the hook here. But I guess one more question for you, which is a bit of a tricky one, because considering you said you guys don't actually do the models, but I guess using the malaria example, what kind of outcomes can you see for the predictive analytics that you you could do with COVID eventually once we get richer data sets. How do you see that directly impacting maybe pandemic response, policy, and potentially even treatment?
Yeah, so definitely. So we specifically, let's say IBM Research Africa, we're not like modelers, but we do have colleagues in the other IBM research labs that have done incredible work on modeling for COVID-19. So we do leverage their brain power. But in terms of outcomes, I think the point is the decision making, right? So right now people are trying to figure out how do you, what you should implement, where you should implement it, and what you should lift. So the lifting part is very important, and what's the impact on the economy. And in our context in Africa, we've got a different type of socio-demographics, so we can't necessarily just do what other places did. So I think it's that delicacy in terms of outcomes is to be able to better inform that decision-making process to minimize especially the economic impact. Thank you.
Great, thank you so much. That's really interesting, and looking forward to seeing some of the research that results from your very useful framework. So thank you for sharing. Next up, we have Professor Mathai, Associate Professor at the Department of Psychiatry at the University of Nairobi. So Dr. Mathai, I think you're with us, so I'll hand over to you.
Thank you very much, Nicole. Good afternoon, everybody. Thank you very much for inviting me to this forum, which I did not know about before. It's very interesting to see all the different people from different working areas and their specialities. When I was asked to make a presentation, I thought I sort of target on the area which for us in mental health is really important, and which has a very direct impact on the COVID-19, and that is about behavior change. So I'll mainly be talking about behavior change and the key players who should be involved, and maybe from time to time refer also to the study that we have just initiated to provide psychosocial support for health providers. Next. So the motto of this was, the key statement was one size fits all, incorporating social science in holistic approaches to tackling COVID-19. And when I looked at this, I thought about some of the things that the COVID-19 pandemic has highlighted, including the question of human behavior in the control of disease spread. Of course, this is not the first time that human behavior is directly involved in disease control. But it has also brought into focus gaps and cracks that have already been there in the public health sector, in the social sector, and we're finding that most of the difficult areas that we are having, it's areas where we already had cracks already even before, whether it's overcrowding, whether it's lack of water, whether it's lack of hygiene standards, overcrowding in schools. There are very many areas where we already had problems, and what the pandemic is really highlighting these areas. Now, the other one is what really is being addressed here, and is that the needs for multidisciplinary collaboration and multi-sector collaboration, and the involvement of the community, which is another area where we've had a lot of problems, like a lot of things that have been done in the prevention, in control of spread in Kenya did not involve the communities in the initial in the initial stages, and that has been quite a problem. Next. So the story that we have here is a story. It's a story of a pathogen which is biological, no question about it. This belongs to the natural scientists, but it is something that's moving from one person to another one. And so there's that question of the contact between people and the social relationships, which are so important. it is about information transmission. And this is another area where we've had a lot of difficulties, including messagings. What kind of messages are we giving? How are these received? How are these messages interpreted? And then it's about the needs, the question of the individual needs to do what they need to do to protect self and other. So the question is, does this protect the other, or am I protected, or what does it mean, protect self and protect the other? And it's also about what the state needs to do to contain a spread and also preserve the well-being of the people. It's the economics. And of course, finally, it will be the story of a lasting viable solution, which we haven't yet arrived at. Next slide, please. Now, and the kind of behavior we are talking, this is some very interesting drawings or murals in the slums of Nairobi. It's about mainly 4 things that we've been talking about in our context. It's about physical distancing, frequent hand washing with soap, sanitizing, and wearing a mask in public places. So this is a behavior where we are saying, some of this is behavior we're saying we want to people to adopt new types of behavior. Sanitizing is not really something that is a tradition in our culture. Hand washing we've been talking about for a long time. Wearing a mask is something completely new. I mean, I know there's some places in Asia where wearing a mask is the norm, but we are also not telling people just to change their behavior, but to adopt new behavior. And for this kind of thing, you really need to be very cognizant with how do you deliver new behavior into our community. Next, please. Next slide, please. Now, then one of the things that I found interesting is the role of health historians in this pandemic, which has come up, which we don't usually have a lot of time for history in our health systems. But somehow suddenly it's come up and we said, oh, so this is not the first time it's happening. So populations have been there before. And maybe history does have an important role to play, because it means that there may be lessons which have been learned before, which we don't need to reinvent. Next, please. So the issue that we're talking about, behavior change, and that's why it's so important for me to have a multidisciplinary approach, is that behavior change, or the adoption of new behavior, as we are expected here, is at the very basic level, is an interaction of the person, the environment, and the type of behavior that we expect. And this is where the different disciplines, unless they work together, to get these changes, you don't get it, because if you run away with one of them and the others are missing, then it means that you fail. There is and we are full of projects, full of them, which have failed because one area took off with a project and did not integrate other disciplines who were more specialized in that, who bring in something very important. And this is one of the things that we're doing in our current project, is trying which our project is about the acceptability of telemedicine approach to psychosocial support for frontline workers. And what we're trying to do is bring in as many disciplines as possible. Next. You can see my time is running. Next, please. So behavior change is the domain of a wide range of specialists that center around social sciences with a lot of overlap. Next. Next, please. So here are some of the people we're talking about: the educationists, the sociologists, biologists, health, criminologists as well, psychologists, and what we may not have here as the health economists as well, and maybe anthropologists. Next. Now, I really like this because it reminds me of my earlier days as a student of community health, where they said you can come tell people to build latrines. It's so easy. They put it up, but they will not use it if it's not within their culture and they do not understand why. So you're a health scientist. You said, yeah, this is what you need to prevent disease. Then you come 1 year later, nobody is using your toilet. It's there. You wanted it built. It's been built, but nobody is using it. Next, please. So basically, what we're saying and what we're trying to work with in our project is to say, we need all these people, and we have sociologists, we have social workers, we have doctors, we have psychiatrists, we have an educationist also. And this is an area where we don't have a lot of support. That is communicators, education, people who are experienced in communicating messages. And we need to really invest in that area. And then we have, of course, your policymakers. If you don't work with them, then who is going to support your project? And most important, it must all be based on the community. That must be your base, because what we've been having is a lot of top down. So, so what we've done in our project is we've tried to bring in stakeholders of the health workers, the unions, the association, as collaborators, so that they are able to go out to their community of people, that is our community, and bring it and engage them. Because if you don't engage the community, then there are lots of people who will feel like it's not about us, you know, it's something coming from above. Next. I hope I haven't taken too much time. Thank you very much, everybody, and stay safe.
Great.
Thank you, Nicole.
So much for that, Professor Mathai. That was really great and really interesting. And I think just before the webinar, we were talking a little bit about how often this is overlooked by policymakers. So I think that's posed some really interesting questions. And I think a couple of questions from me, as always. But I think one of the things you touched on was around the misinformation and clear messaging to the public. With my policymaker hat on, I guess for them also it's difficult to have a clear message when the science is constantly changing. Is there some sort of in the middle solution in terms of how we're communicating what to do to the public, that we can do it in such a way that prepares them for the fact that this might change? Because that's partly it. The expectation management doesn't seem to be met. So it'd be interesting to get your thoughts on that.
Yeah, I think for me, one of the things is that we've been sometimes giving people message as if it is fixed, as if it's a fact, and yet we know it's not, because we don't know. So and clear messages like we're asking you to wear masks, not just to protect yourself, because this became one of the biggest controversies when everybody started saying, yeah, but a mask doesn't protect you, this type of mask doesn't, and this one does, and this. It's not just about you. If I protect you and you protect me, we have created something. And this is some of the things that are not coming across. So let us not make statements as if we know it all until we do, because at the moment there's still a lot we do not know, and that is becoming really confusing for the public, but also even for the health providers. I think that's
very true. And I think the other thing that stood out to me was that you mentioned this, how adoption of behavior is this interaction between environment, person, and the type of behavior we expect. So it feels like that marries almost quite nicely with the idea of the policy being related to the environment. So that's the government creating the environment, the person being the community, and the type of behavior being sort of the outcomes. do you have any, if there were any government ministers listening, any tips for them on how they can leverage all three of these at once? And for me, most importantly, looking at bringing community in a meaningful way, because you often hear policymakers talk about that, but it doesn't happen meaningfully. So any thoughts on that?
Yeah, I think one of the things that I really feel would be important is for the policymakers also to go down and engage the community in dialogue. Okay, even if it's just group discussions or let's hear. We have something in our country that is been practiced for many years called chiefs barasas. Okay, this is something we did not get. We didn't get chiefs barasas where people ask, what can we do? This is our community. This is the situation. What can we do? Are you people, what do you think is practical and what is not doable? Instead of sending the police to beat up people. And you remember, when you say, why did Kenya adopt the mask so easily? Because you know, it's not because people really think they understand or they think it's useful, but it's because you're going to get caught by the police. You might get beaten up, or you're going to have to part with money because you're not wearing it. So I think this, what we already had, this kind of chiefs baraza sort of thing, which we used to use quite a lot in the past in health related matters, is something that sort of like has dwindled, but which was not really, people are not really engaged. They didn't really understand. So people are depending on social media, and every day there are new stories. And so that would be what I would say. Yeah.
That's really interesting. And I think Dr. Webb, you have your hand up, so we'll let you ask a question.
Thank you. That was a really great talk and really super interesting. I'd like to just ask, from your own point of view, what you postulate about the long-term effects on people's mental health and on societies and culture in general of this pandemic. I know there's, we can't say anything for sure at the moment, but what is your feeling about how that will play out?
Yeah, one of the things that we know is going to happen is, like, and already happening, is an increase in mental health problems. We have also had an increase in violence, domestic violence, particularly because people are so cooped up together. And the mental health problems, particularly related to young people who really can't stand this being enclosed in small spaces. And then again, some of the things we told them not to do before, not to spend too much time on social media, we are now asking them, communicate with your friends on social media. So so we're going to have I'm afraid for our society, because we're going to have changes that we've never had before. People are starting to get afraid of strangers. You walk on the street these days, and you're also afraid. You're walking, you're keeping your social distance. So there are going to be changes that are dramatic, and culture is about change. So we have to find a ways of living with them. So one interesting thing just to mention is, like, we've always been very body people, physical, hug, and it became so the thing, and suddenly we have one cult, kind of Christian cult, that doesn't do physical contact, and they always wave at you. They say, it's good, and you see people are doing that now, so we're getting changes which you didn't expect. You meet your friends and you're waving, it's good, and things are going to change, Dr. Webb. I don't know where we will be 5 years from now, but I think we'll be somewhere else culturally.
Yeah, thank you. That's a really, really interesting insight. And yeah, I think you're right. It's going to be fascinating, scary, potentially good change. Some of it might be to see where we all end up as a society in a few years. So thank you so much for that. We had one question from the audience. I believe this was for Dr. Naika from Pauline Esser, who said, thank you for your presentation. And it's understandable that a rapid closed call for COVID-related research was launched as an emergency. However, would that not also stifle innovation? So will there be other open calls announced soon to enable other researchers to submit relevant proposals for funding?
Absolutely, yes. I mean, that was very much within a few months of the, well, actually within 1 month of the pandemic, but we are definitely looking at future calls. I mean, obviously that dependent on the funders and the raising of the money, but yes, that's exactly where we're hoping to go in partnership with our funders.
Great, thank you so much. And now this is the sort of open floor section of the webinar. So those who are watching through the BOBAB platform, there's a live chat in the sidebar which you can ask questions in. And those of us who are actually with us on the Zoom, we also invite you to ask some questions in the chat or put your hand up if you'd like to be invited to speak. That also applies to the panelists, because I think we've had some really interesting topics covered, and I for one would like to dig deeper into some of them. So, but I don't want to be the only one speaking.
Just a quick one from me, Nicole. On the topic, Professor Mathai mentioned the idea of being scared of people, which when we were coming up with this, the idea for this particular event, part of our thinking and the rationale was around the stigma attached with infectious disease, and we were reading earlier on this month that the Kenyan government, I believe several African governments following suit, are increasingly encouraging families to care for sick patients at home. So more care home-based care. The principal idea being to relieve any stress or on hospitals, and to encourage people to use hospitals again. With the specific question of stigma, I just wondered how, in Professor Matai's experience, you can go about addressing that. Is it a big public education piece? Is there, what exactly can be done to help address that particular aspect of the fear element?
Yeah. One of the things has already happened. Initially, and that was we had enforced quarantine. People were being tracked and chased and followed and being forcefully quarantined, not because of a contact history or something like that. And that's created a lot of stigma, because some of the places where they were being put in was boarding schools, and where there was a lot of mixing of people, and people say, what's the point? There's been a lot of fear, and then there's been a lot of fear around the appearance at funerals, with this sort of very fearful, dressed up, and so one of the things has been that lifting of forced quarantine and isolation has actually improved that, and unfortunately we had also stigma against health workers, that a lot of people who work in hospitals, and they're known that work in isolation, or they're just in hospital, they go to their villages, nobody wants to go near them, because they might have brought COVID from the hospital, their hospitals. So it's a drama that was surrounding the reaction that was creating it. So I think the more we start to not making it so dramatic, not to react so dramatically as a state, the more likely we are to lift the stigma, because people started running away, and hiding, People went for tests, and then they gave the wrong numbers, telephone numbers, So I think this does help, but there needs to be a lot of public messaging going out. Yes. Thank you. I hope that answers. Maybe not quite, but
it does, absolutely. I mean, I think it speaks just to the complexity of the challenge.
Yes, it is. It's very challenging.
Of course, vast, but like you say, public information is absolutely crucial to perhaps dial down, the factor. Just a couple of other very quick points from me. Well, more just inquiries, I guess. To Isavani, you mentioned that there was potentially a document around the COVID priorities the Academy had sort of put together, and that we might be able to share it. I wondered if we could help disseminate that as well, and if you wanted to share that with us, I'll send it out to the participants so that they can access it as well, if that's okay.
Yes, definitely. It's also a link on the presentation, but maybe you can't access it there. But I will send you a PDF copy of it.
Oh, perfect.
Yes.
Okay, well, I will embed that within the event summary document that I'll share with everyone. And yeah, just one final inquiry for me again. Aisha, you mentioned that you guys were sort of building out this COVID specific platform and it would be available soon. Probably $1 million question, I guess, but any timeline on that as to when that will be available and when we might be able to share something similar as well?
Oh yeah. So the platform itself, different parts of it have been, released in the past. For the COVID specific elements, that is, I would say in the next few weeks or so. So not too long of a timeline, and happy to share with you if you want to, disseminate in any way. Again, your audience is definitely the audience that we're trying to help and support, and it's really for public good and for science.
Yeah, well, I've come across some of your IBM stuff before, and I know how valuable it's been. So if we can do anything to help spread the word, then that'd be great.
Wonderful. Thank you so much.
No worries.
Good.
That's it from me, Nicole.
Thank you for those questions, and we look like we are finishing right on time. So this is I hope I've done Robert proud here by my timekeeping. Thank you very much. So yeah, thank you again to all the wonderful speakers for your time and sharing your insights and bearing with all of my particularly nitty questions. And in addition to all of those who are watching on the live stream, once again, don't forget that this conversation can be continued on the BOBAB platform. So if you have any projects that are particularly interesting that you want to showcase, you can upload a project there. And if you want to make contact with any of us or the speakers, we all have profiles there as well where you can chat, and more resources will be available. So I think the crucial thing of webinars like this is that there are a lot of them happening at the moment. It's easy to feel quite fatigued. But what we want these webinars to do differently is to lead to tangible change and actionable insights and things that we can all take away. So I know that I've taken away quite a lot that we can put into practice in Medixus from all of the speakers, particularly Dr. Webb's insights about the paediatric impact, and also Dr. Mathai, Professor Mathai. A huge part of what we do is behaviour change, so I'm particularly interested in those aspects of it. So going away and thinking about the lessons we can all take from this webinar and put into practice to help with our own little bit of the COVID response that we're all doing. So thank you again, everyone, for your time. And we look forward to seeing you next week for the next webinar. Oh, actually, I should say, I should give the speakers an opportunity to have any passing closing thoughts or tidbits you want to share before we close off.
From my side, no, but thank you very much to Nicole for such expert management of the time and the great questions, and Nick for the invite, and to the other panelists. I mean, I think it was very, very, very rich and interesting discussions. Thank you.
Okay, I think the silence may mean everyone else is fine to end there. All right, well, thank you so much, everybody, and have a wonderful day, and we'll see you next week. Thank you.
Thank you.